So again, welcome. And I want to give you an overview where we are and what may happen in the near future. And I hope it works now. Oh, yeah. So here are my conflicts of interest. So first, I want to show you where we are worldwide and give you a little bit of feeling what happened during the last 2 years. So we have about 270 million cases worldwide and a huge increase in infections during the last weeks, which is a consequence of the Omicron variant. And I will come back to this later on. Altogether, 5.6 million people died, which is a case fatality rate of 1.5%. And if you look to it in a worldwide view, this is about 3 times more deaths than with influenza during pandemias before. So these are the numbers in Germany, and I want to use it to explain what happened during the last 2 years. So we started in spring 2020 with the classical, the Wuhan variant, a very low incidence because Germany was reached by SARS-CoV-2 in March, and then very early spring was present. And to make it clear, the SARS-CoV-2 virus is no question about weather-dependent virus, so it's much more prevalent in autumn and winter times. It's much more prevalent in countries where it is cold and humid during the autumn and winter time, and we see low incidence in summertime. Then in autumn 2020, we had a very severe wave, also caused by the classical variant. And the difference between the first wave and the second wave was the main age of the ones who are infected. So in spring, mean age was about 55 years of age. In autumn, it was close to 70 years of age. And to point it out, the strongest relationship to bad prognosis in SARS-CoV-2 is the age. So as older you are, as more comorbid you are, as higher your likelihood for severe course of COVID-19 and for mortality. Then in spring 2021, a new variant occurred. It occurred first in the United Kingdom and then moved all over Europe, and this was the Alpha variant. And the difference between the Alpha variant and the Wuhan variant is a higher transmissibility, so more people infected. However, and this is true for every new variant which appeared, if they are more transmissible, they are less virulent. And even we had high case numbers, we had a lower mortality all over. Then we had a very calm summertime on the Northern Hemisphere, and in spring, in autumn, the Delta variant occurred. And the Delta variant is about 50% more transmissible than the Alpha variant and about 100% more transmissible than the classical variant. So we see high numbers of cases. The incidence with the Delta variant came down around the beginning of December in Germany, but very immediately, and this came from Africa, and the first cases had been reported from South Africa, and then in Europe, in the United Kingdom, the Omicron variant appeared. And the Omicron variant is a very, very transmissible variant. There is a variation of the Omicron variant, which is Omicron BA2, which is again more transmissible, and therefore it causes a huge number of infections. And here are the data for Germany. You see, during end of December, beginning of January, we had a dramatic increase in incidence up to 1,100 per week. Now we had a small increase in hospitalization rate, but because this Omicron variant is very, very low in terms of virulence, we had no patients on the intensive care unit, and the patients who are on the intensive care at the moment are from the Delta wave. So Omicron very seldom is followed by a severe disease, which make mechanical ventilation necessary. And here the data from the United Kingdom, and as you can see, the United Kingdom was the country which first started with Omicron in Europe. In the beginning of December, the incident raised to about 2,000 a week, and now it's coming down day for day. Yesterday it had been 954, and the numbers of patients hospitalized is going down more and more. And in terms of patients on the ICU, it is the lowest number since June 2021. And this is because this Omicron variant does not have a pulmonary phenotype. So pneumonia is a very seldom event, and respiratory failure is very rarely present with Omicron disease. So if you look to the mortality rates over the time, and again, these are the data for Germany, I will come back to the Gulf region in a minute. You can see with the classical variant at the beginning, we had 2.3%. With the classical variant in autumn, it increases to close to 5% mortality, and I will show you why. And then it went down with Alpha, with Delta, and with Omicron now, we had a mean mortality rate over the last 2 months around 0.2%, which is the half of the case fatality rate in a normal flu year. Well, what are the reasons why the mortality is going down so quickly? First, it's the attenuation of pathogen virulence. If you look into the evolution of infectious agents, the power of a virus is always the same. And if you spend power for being more transmissible, you lose power to be very virulent. And this is what we see now. The Omicron variant is really the most transmissible one we ever have seen for coronavirus, but the pathogenicity is very, very low. Then, and you will hear this later on, there are new treatment options available, antivirals, monoclonal antibodies, which make a difference. The two issues I want to focus on are the age of those who are infected and the vaccination rate. First, I want to show you what happened in the Gulf region, and I put the data for the United Emirates out of the Johns Hopkins registration. And what you can see is it's the same, little bit the same pattern of waves in the Gulf region that I showed you for Germany, the first wave with the classical variant, the second wave with the classical one, then the Alpha wave, the Delta wave, and now the Omicron wave with an increase in infected patient numbers. But the difference, if you look to the Gulf regions and a lot of countries, it's more or less the same for a country like India or other Asian countries, is the age distribution of the population. And here, out of the international data registry the age distribution in the United Emirates. And as you can see, only about 1.3% of the patients is over 65 years of age. Well, there is a very, very close relationship between age and severe disease and mortality. Patients who are below 30 years of age, more or less, never are severely ill and never die. The mortality rate in the under 30 years of age population is lower than 0.1%. And it increases with age, but it mostly affects those who are very old and who suffer from a lot of comorbidities, mainly cardiovascular and metabolic comorbidities. Well, one of the most important issues with regard to the corona pandemic and with regard to the future of the corona pandemic is vaccination. And what do we know now? Well, it's quite clear for the Omicron variant, and I will show you the data. If you are 2 times vaccinated, which we had called a fully vaccination a year ago, the immune response is not as good as expected. So you need a third dose of the vaccine to get a high efficiency. And even with the third dose, the efficiency is lower than it has been for the Wuhan variant or the Alpha and Delta variant. Nevertheless, all vaccines which are approved in the United States and in Europe are effective. And this is true for the mRNA vaccines, BioNTech and Moderna, the adenoviral vector vaccines from AstraZeneca and Johnson & Johnson, and also the new protein subunit vaccine, Novavax, which is now approved in Europe. Yes, there are side effects of vaccination, but they are altogether much fewer than previously thought. And the most important side effect with regard to the mRNA vaccines is myocarditis, mainly in young men, or it's more myopericarditis. To be honest, it's different from a normal form of viral myocarditis. It's a very mild form of the disease. Arrhythmias do not occur together with this, and the myocarditis after vaccination is normally solved in between 2 to 3 weeks, and sudden heart death as the most important complication has not occurred. Adenovector viral vaccines caused autoimmune thrombocytopenia with an increase in sinus venous thrombosis and abdominal vein thrombosis. However, the adenoviral vector vaccines in Europe are no more used, and so this form of side effect is no more present. Let me spend 2 words for vaccines which are not approved by the EMA, the European Medical Agency. And this is the Russian vaccine Sputnik. Why? And the reason for this is a mix of different adenoviral vectors. And what have been shown is that the production process of this vaccine is not very valid, which means the dosages are different from charge to charge. And this led to an increase in side effects, and the side effects had not been reported to the European regulators by the Russians, so there was no approval of this vaccine. The second one is an inactivated virus vaccine. There are a lot of companies around the world which produce inactivated viral vaccines, and the best known is a Sinopharm vaccine, which is used in China. Unfortunately, these inactivated virus vaccines are very, very less effective against the Omicron variant. To be honest, they are not affected effective, which means in countries like Chile, for example, or China, which use these kinds of vaccines, mostly there is a very bad immunity for the Omicron variant. If you look to the efficiency of the vaccines and the different vaccines to the different variants, you can see that every new variant leads to a deterioration of the immune response after vaccination. And this is mainly true for the adenoviral vector vaccines, though the mRNA vaccines, BioNTech, Moderna, caused a better immune response than the adenoviral vector vaccines. And with Omicron now, the immune response is the worst one in comparison to the other variants occurring before. What is quite clear now is that homogeneous mRNA vaccination, so first shot mRNA, second shot mRNA, or heterologous vaccination, first shot adenoviral vaccine, second shot mRNA vaccine, is both more effective in terms of humoral but also cellular immune response than a homogeneous adenoviral vector vaccine regimen. And for the third shot, the mRNA vaccine is recommended to be used. There had been a nice paper months ago from the Oxford group looking to the different vaccines which are used for the third shot, the booster shot of vaccination, and altogether they showed that both mRNA vaccines, but also the protein subunit vaccine, the Novavax vaccine, can be used for the booster shot and is highly effective. Looking to some special patient populations, there had been a question whether in adolescents and in younger children vaccines are effective. And these are the data for the adolescents with the BioNTech vaccine demonstrating effectiveness, which is the same as it is in adults. And here the paper for the younger children, the 5 to 11 years of age children, demonstrating a similar efficiency than in adolescents and in younger adults. And as you can see here, the efficiency rate is up to 90% and very comparable to what we have seen in other populations. And very important, and one of my most important issues, there had been a discussion what happens in pregnant women. Pregnant women have a high risk for severe course of COVID diseases, had been highest with the Alpha variant. And in the top times, we had more than 10 pregnant women ventilated on the ICU. This has something to do with Th1, Th2 shift during pregnancy, and you need Th1 interferon gamma activity to fight the virus, and this is worse during pregnancy. So normally medication is not studied in pregnant women because of risk estimations, and so we need registry data. And now we have a lot of registry data for pregnant women with the vaccines, and it had been shown that it is highly effective, it's safe, there's no increase in abortion rate or side effect rate in pregnant women, and it should be used and is highly recommended to be used. One of the major problems with regard to Omicron, and I said it before, is that the immune response is coming down over time. And it's much more coming down in the elderly and in patients with comorbidities and patients who are immunosuppressed. And this is what you can see here from the Israeli data. Having this in mind, a booster third vaccination is strongly recommended. And again, the Israeli data are demonstrating that with a third dose, there is an increase in efficiency, again up to 90%. But these data are for the Delta variant, and they may be not as good for the Omicron variant. Here, the numbers for the Delta variant. One patient population which has to be taken into account are the immunosuppressed. And these are the transplant patients, the cancer patients, mainly patients who are treated for hematological diseases, leukemia and lymphoma, and the patients with autoimmune disease, which are treated by a B-cell depleting regimen, for example, rituximab. And these patients do not have an immune response to the vaccine. Here, data from the Paris group published in the New England demonstrating that 50% of the transplant patients do not have any immune response to 2 shots of vaccination. And even with a booster shot, it's not much better. What we expect is that a long-term effective monoclonal antibody, and I hope this will be tackled in the next talk, will come up. It's the ACD7442 antibody, which produces antibodies for more than 9 months, mainly a year, and this can be used as a protection instead of vaccination in these number of patients. So my last slide, what do we know about a 4th vaccine shot, a second booster? The program had been started in Israel. It had been shown that for the younger people, it's not effective. So they proceeded now for the elderly. But I'm not convinced it's a wise strategy for 2 reasons. If you use a vaccine shot too early after the last vaccine shot, the immune response is worse than if you have longer durations between the vaccine shot. And here in Israel, the duration between the 3rd and the 4th shot is very short. And I'm not sure we want to do this with Omicron. Omicron is a very, very low virulent variant of SARS-CoV-2. And with Omicron, we are moving forward from a pandemic situation to an endemic situation, which means we have a viral disease, and we know a lot of these viral diseases, for example, rhinovirus infection, nose sneezing, which is all around, and this is present, but it's not dangerous, and there's no overload of the healthcare system. So maybe Omicron is the development into a situation we have to learn to live with, but which is no more dangerous. And this is the reason why the development of an Omicron-based vaccine is not really very quick. Nobody knows whether we need an Omicron-adapted vaccine and whether it's wise to use it, because Omicron has overcome Delta, a less virulent variant has overcome a more virulent variant, and this is what we want. And a very last comment, what about vaccination in the youngest children, the below 5 year of age children? And here the first data are disappointing. The immune response is not good enough, and it is not recommended for several reasons. So my final comment, Omicron SARS-CoV-2 will stay, but it will not be so threatening than the years before. So we have to learn how to live with this kind of variant. And if we do this, we will come back to a normal life soon. Thank you very much